Today we're going to continue with the medically compromised patients and we'll talk about respiratory medicine. Now, the respiratory tract consists of two parts: the upper, the nostrils, the paranasal sinuses, the pharynx, and the larynx; the lower respiratory tract, the trachea, the bronchi, and the bronchioles; and the lung itself, the bronchioles, the duct, the sacs, and the alveoli. Now, in all of the upper respiratory tract, we will have mucociliary lining. It has cilia that protects the flow, filters the air that goes into the body. Now, the lung functions to oxygenate the blood, to give oxygen to the blood and to the cells, meanwhile taking out carbon dioxide from the body to the outside. The most common lower respiratory tract disorders are asthma and COPD. Now, upper respiratory tract infections include flu, include the common cold, which can be viral or bacterial. Now, can we define if it's viral or bacterial? Now, bacterial infections include tuberculosis, include streptococcal infections or strep throat, upper respiratory tract infection. These are bacterial infections, and here we need antibiotics. Now, the viral ones are the most common ones: the common cold, the flu, the sore throats. These are the common ones, and these are viral infections. Now, the signs and symptoms usually are the same in all respiratory infections, including sneezing, mucus overproduction, nasal obstruction. Now, bacterial infections might cause sinusitis or otitis media. Now, the general management: if it's not controlled, do not treat your patient. If it's elective, do not treat your patient. Now, if it's urgent and we need to do the procedure, we have an irreversible pulpitis, we have whatever problems the patient might have, we stick to cross infection control. We place the patient as the last patient in the clinic, and then we try to do cross infection as much as we can. Now, the more common type is asthma. Now, it's a very common disease. Now, here what happens is that there will be an allergy. If the patient is allergic to an specific product in the world. Once this product or once this thing the patient smells it, there will be muscle spasm. There will be reversible airway obstruction. Due to smooth muscle contractions, the muscle will constrict, they will contract, they will cause bronchospasm. This will be a reversible airway obstruction. Then there will be mucus overproduction and mucosal edema. There will be swelling and hypersecretion of mucus. And of course, it's reversible, because if it's irreversible, the patient dies. Now, there are multiple things that can cause asthma or can trigger asthma: infections, irritating fumes, exercise, weather changes, anything that might cause an allergy. Now, we have two types: we have the extrinsic and the intrinsic type. The extrinsic mostly in children, and it's the most common type. Usually, there will be allergen causing IgE mediated mast cell degranulation. The intrinsic is less common, and usually it's hyperresponsivity with mast cells instability, and more common in adults. Okay. Now, the clinical features: patients will complain of dyspnea, cough, expiratory wheeziness. Now, what medications do these patients take? We have beta agonists, selective beta 2 agonists, antimuscarinic bronchodilators, corticosteroids, mast cell stabilizers. All of these are common medications that the patients might take. We all know the inhaler that these patients take, and more and more. So, these are the medications that the patients might take. Now, one of importance is the thiophyllin. Now, theophylline is a natural occurring product found in tea, in multiple other natural stuff. Now, it helps it's a bronchodilator. Now, once we give the patient local anesthesia, what does the local anesthesia have? Adrenaline or norepinephrine. Now, this norepinephrine or epinephrine and theophylline, they will both. Now, theophylline alone raises heart rate and blood pressure. Adrenaline or epinephrine raises the heart rate and the blood pressure. So together, they will cause a high rise in the blood pressure and the heart rate. So they're mostly contraindicated together. Now, the general management, patient education, avoidance of identifiable irritants, and the medications. We need to know when we do this to any asthma patient, when we do any dental procedure to an asthma patient. Is it controlled and is it urgent? Now, if the procedure we're doing is elective, not necessary, and the patient has uncontrolled asthma, we don't do the procedure. We delay, defer, send him back to his pulmonologist, and then he comes back to us. If it's controlled and elective, we can do the procedure. If it's controlled and urgent, we can do the procedure. If it's uncontrolled and urgent, here we can do some modifications. We can give him corticosteroids, we can give the inhaler, and many other things that will at least delay the procedure happening. Now, we need to know when we take history from this patient, we need to know when was the last time he had an asthma attack? When was the last time he needed to go to the emergency room for the asthma? Okay? Now, if it's very soon, we defer the patient. If it's elective, of course. Now, of course, always we can take a consultation telling us what to give, if we can do the procedure or not. Okay? Great. Now, can we give these patients non-steroidal anti-inflammatory? No. Non-steroidal anti-inflammatory medications, these will cause bronchoconstriction, so they will worsen the asthma. But in some cases, some patients have taken ibuprofen and there is nothing wrong with them. So we be careful in these cases. We ask the patient, have you taken any non-steroidal anti-inflammatory medications before? He says yes. Did you have any problems with it? No, not that I remember. We can then give it to the patient. If he said I never took it, we stick to paracetamol. Benzodiazepines should not be given because they are respiratory depressants. And of course, we treat the patient in the late morning appointment. Now, chronic obstructive pulmonary disorder, it's two diseases together. Chronic bronchitis, which we call blue bloaters, and emphysema, which we call pink puffers. Now, blue bloaters, because these patients would be cyanosed because there's not much space for the air to go through and exchange between the lung parts. The pink puffers, because the alveoli will accumulate to each other, so they will raise the surface area of the alveoli. This will cause more air and more blood coming to the area, causing them to become pink puffers. Its number one cause is smoking. Patients would complain of breathlessness, wheeze, airway obstruction, morning sputum, early morning sputum. Once he wakes up, he has a lot of sputum in the morning. Now, patients should be educated and lifestyle modifications and medications. Now, these patients can be placed on CPAP, BiPAP, a lot of things that can bring air or oxygen into the body. We treat them in an upright position at a mid-morning or early afternoon. If we want to use rubber dam, can we use it? We can. How? we make a hole in the dam itself. So when we can place a suction, the patient can breathe easily and everything can go well. Now, diazepam and midazolam should not be used. As we said, these are bronchoconstrictors, direct respiratory depressants, and the patient should stop smoking. Now, if we're going to go for GA, he should stop it for at least 8 weeks before the procedure, but most patients cannot do that. So we ask them to stop it 1 day before the procedure at least. Okay? Now, always, whenever any patient comes to us, we ask them to bring all their medications. Specifically, asthma patients and COPD, if they're taking any specific medications, we ask them to bring it. Like asthma, for example, these patients take the inhaler. We ask them to bring it with them because once the patient sits on the chair, we ask them to take one inhaler shot. Then once we give them anesthesia, we ask them to take another one, and so on. And if we have corticosteroids in the process, we need to do double the dose if needed, depending on how long, and as we said in the last part. Now, gastric diseases and hepatic diseases. The most common is GERD, gastric esophageal reflux disease. It's a backflow from acid from the stomach into the esophagus. The usual symptom is heartburn. Now, usually patients, we ask them to losing weight and stop acidic foods, and drugs like H2 blockers and proton pump inhibitors. Now, patients would have erosion in the palatal side of the anterior teeth because of the acid reflux that reaches the palatal side of these teeth. Now, peptic ulcer. It is an ulcer, a defect in or close to acid secreting areas in the stomach, which we call gastric ulcer, or duodenal ulcer in the duodenum, proximal duodenum. Usually it's very common in males over 45 years of age and affects up to 15% of the general population. Now, H. pylori is kind of the culprit, the main culprit in this process, because H. pylori is a bacteria that's present in the stomach. Now, once the patient has an ulcer, it can help in making it worse. Now, for H. pylori, we can give the patient either triple therapy or quadruple therapy. It contains proton pump inhibitors and 2 antibiotics, usually amoxicillin and clarithromycin. If it's quadruple, we add metronidazole. Okay, great. Patients will complain of epigastric pain, and some patients might have it symptomless. Now we ask the patient to have small meals, frequent small meals with no fried food, stopping smoking, and alcohol moderation. Non-steroidals are contraindicated because non-steroidals will get rid of the prostaglandin layer over the stomach, and this will cause loss of protection. So this will cause more ulcers and more pain. Now, these patients, because they cannot take good amounts of food, B12 may be low, folic acid may be low, iron may be low, and sometimes these patients might have gastric surgery. So they can result in hypoglycemia. So we need to be careful of all of these. These patients can have angiostomatitis or sore throats. Now, celiac disease is the great mimic of medicine because its symptoms are very similar to many diseases. It's hypersensitivity or toxic reaction of the smallest intestine mucosa to gluten. Now we ask patients to stop gluten and CBC to check for anemia. And patients might have aphthous-like ulcers and burning mouth syndrome problems. Now, inflammatory bowel disease is usually a collective term for the diseases that cause inflammation in the intestines. Now, the general management usually, we just try to stop anything that might cause the inflammation. We protect the anemia. Patients might have B12, iron, folic acid deficiency, we try to bring them back. Okay? Now, antibiotics may be needed. Patients might have oral lesions, like the one in the picture here. Fissure tongue, geographic tongue, all of these can be seen in there. And they have a higher risk for caries and periodontitis. Now we have two diseases, Crohn's disease and ulcerative colitis. Now, usually the higher carcinoma risk is present in Crohn's disease. Now, irritable bowel syndrome, or what we call spastic colon or mucus colitis. It may affect up to 30% of the population, and it's the most common cause of referrals for gastroenterologists. Now, clinical features usually recurrent abdominal pain, increased tone and activity of the colon, abnormal bowel habits, and other symptoms. It's more common in females. We ask the patient to stop, reduce the stress, and a high fiber diet. Patients might complain of dry mouth or atypical facial pain. Now, hepatic disorders. What's the function of the liver is metabolism. Metabolism for many things, for medications, for anything that we might get. Now, chronic liver disease can be called chronic hepatitis or acute hepatitis, or liver disease in general can be acute or chronic. Now, if it's less than 6 months, we call it acute. If it's more than 6 months, we call it chronic hepatitis. And cirrhosis. Cirrhosis is basically transformation of the liver parenchyma into fibers. For chronic hepatitis, the most common causes are hepatitis C, alcohol, drugs, or autoimmune hepatitis. Now, these patients might be on immunosuppressants, these patients might be taking antibiotics, these patients might have a lot of problems, and that's why we need to be careful. Most important for us, these patients might be on anticoagulants. These patients might have problems with bleeding because the liver is not functioning properly. So we need to be careful with the PT, the PTT, the INR, and we'll talk about them later, but we need to be careful. These patients do not produce the actual or the clotting factors that we need. So we need to be careful with this. Now, dental aspects, lidocaine, prilocaine, bupivacaine, all of those are metabolized in the liver, so we cannot use them and be sure it's safe to use them. Articaine is actually double metabolized in the plasma cholinesterases and in the liver. So it's considered the safest or the best of the worst, let's say. The safest to use in patients with liver disease. And we need to reduce the doses of the medications that we give. For example, if I'm going to prescribe amoxicillin or clavulanic acid, if I prescribe 625 milligrams 3 times daily, I need to reduce that into 2 times daily because the liver is not functioning properly. And we need to be careful with the cross-infection control because these patients can be carriers for hepatitis, HIV, all of the rest. Now, cirrhosis, as we said, it's the transformation of the liver parenchyma. Now, the most important thing that we need to know is that it can cause parotid swelling or sialosis. Here are the liver function tests that we can order for any patient that needs it. Now, hepatitis viruses. We have A, B, C, D, E, G. A and E are fecal-oral transmission. B, C, and D, parenteral transmission. B is the most or the highest percentage of infection to us. It can be transferred in 30% because it's present in bodily fluids, semen, saliva, blood, all of that. So, 30% risk of infection from a patient to you. That's why we need to be very careful in these patients. We do double measures, double gloves, double masks, goggles, face shield, everything. Last patient and the last day of the week. So we put the patient in the last appointment and last day of the week. And we throw anything that we used with this patient in the red trash bag. And the instruments that we use for the patient, if we can use disposable instruments, that's better. But if we cannot use them, we sterilize them alone in a different set of autoclave. Okay, and it's the only DNA virus. Now, renal diseases. Now, the kidney functions to eliminate anything that we don't like. Now, it's basically blood passes through the kidneys, gets filtered. The good things can be brought back, and the bad things can be thrown away. The GFR is the glomerular filtration rate. It's the amount of blood that passes through for filtration. So normal, it's up to 130. Diminished renal reserve or diminished renal function, we call that when it's between 90 and 129. Between 60 to 89, mild renal disease. Between 30 to 59, moderately severe. Between 15 to 29, severe. And in stage, less than 15 milliliter per minute. Now, dialysis is basically we do the functions of the kidneys when they're not functioning. So we take the blood into a machine, filters it, and then brings it back to the patient. We have hemodialysis and peritoneal dialysis. Hemodialysis can be done at home. Peritoneal dialysis needs to be done in a hospital. These patients will have an AV shunt. Basically, it's a connection between the artery and the vein. This connection between the artery and the vein is very important. So they don't keep trying to cannulate the patient every time. No, they make this connection, and every time they go for dialysis through it. The important thing here, we do not take blood pressure in this arm. The arm that has the shunt, you do not use blood pressure because he's gonna be very hypertensive. We use the other arm. Now we should consult a hematologist. We make our appointments the day after the dialysis. So if he makes the dialysis Saturdays, Mondays, Wednesdays, we do our procedures Sundays, Tuesdays, and Thursdays. We give them antibiotic prophylaxis because they need it, because these patients are susceptible to infections. Now, tetracycline or minocycline, we need to use medications that are safe to the kidneys and with lower doses if we suspect them. Now, these patients might have anemia and might be on or will be on anticoagulants like heparin. So the day after the dialysis, that's where we do our procedure. Now, neurological disorders, basically what we need to do is that we need to reduce the stress as much as we can, talk with the patient as much as we can, and make him calm as much as we can. We do the procedure in early morning appointments with pre-medications. We try to do painless dental procedure with psychological approaches. Now, the most important part, epilepsy, usually recurrent seizures. 1% of the population, the general management usually patient education and avoidance of triggers. These patients might be on phenytoin, tricyclic antidepressants, and many more. So we need to be careful with the medications. We treat when controlled. Early morning appointments, taking all the medications. If an attack develops of an epileptic patient, a fit or a seizure, whatever the name that we're going to use. Now, first, we take away anything that might harm the patient, terminate the procedure, put away any blade, any probe, anything that might harm the patient. We do not put our fingers inside the patient's mouth because the biting force would be very high and it can cut a finger due to its high force. We try to do it mainly at early morning appointments. Flickering lights should not be done, so we don't just keep pointing the light at the patient on and off. We use it only when needed. If we don't need it, we put it away. And that's for medically compromised. Now we're going to talk about bleeding disorders. Okay. So, bleeding disorders. Now, the important thing that we need to take care of is that we took fur in the first part of the lectures about bleeding disorders. Now, we need primary hemostasis, secondary hemostasis, and tertiary hemostasis. Primary hemostasis is basically done by the platelets and the von Willebrand factor. So this will affect the bleeding time, which is between 2 to 8 minutes. And usually there will be vasoconstriction after the injury. The secondary hemostasis is the clotting and the coagulation cascade, and here the PT and the PTT and the INR. The tertiary hemostasis is fibrinolysis, getting rid of this fibrin clots. If we extract for the patient and we find out that there is post-operative bleeding, we extracted the lower six, for example, and when we waited, everything was fine. The patient calls you after 3 or 4 hours, tells you the bleeding is too much. First thing, we need to get back and check if there are any medical problems that the patient might have and we ignored. Now, any medications, whatever it is. Once the patient reaches the clinic, we apply pressure. We apply gauze pressure for 10 minutes. If the bleeding stops, that's perfect. If the bleeding doesn't stop, we give local anesthesia since it has adrenaline and it's a vasoconstrictor, and we do suturing. Figure of 8, horizontal matrix, anything that can cause blockage of the or clot and stop the bleeding. We can apply cold on the area to cause vasoconstriction. If after all of this there is no stopping of the bleeding, we consider a systemic cause. We ask for lab tests, PT, PTT, INR, and all the rest. Now, the first one we're going to talk about is hemophilia A. It's factor VIII deficiency. It's an X-linked disease. Mainly males are affected and females are only carriers. A is more common than B, and it's the most common hereditary bleeding disorder. So here, bleeding time is not affected. Factor VIII is present in the intrinsic pathway. So the von Willebrand factor and the platelets are not affected. They will be fine and nothing wrong with them. So normal bleeding time in these patients. The PT and the PINR, these are usually related to the extrinsic pathway, and there is nothing wrong with them, so we will have normal PT and normal INR. PTT will be prolonged and factor VIII will be reduced. Here, hemorrhage stops immediately after the injury, normal like any patient, but intractable oozing starts to appear, and rapid blood loss follows that. Since factor VIII is missing here, or not functional, we have factor VIII replacement to manage it. Fresh, but it's very expensive. Fresh frozen plasma can be given. This gives us an accumulation of clotting factors. It will be helpful and more affordable. Desmopressin can only work in hemophilia A and in type 1 von Willebrand disease. We'll talk about it later. It's a synthetic analog to vasopressin, and we can use tranexamic acid. Now, we have 3 types of hemophilia A, or 3 degrees. Now, very mild when the factor VIII level is above 25%. Mild, 5 or 6 to 25%. Here, dental extraction, bleeding after it, may be the first sign that we can see. Sorry. Now, moderate, between 1 to 5%, and here we will have significant blood loss. Severe, less than 1%, and 60% of patients with hemophilia A are in the severe stage. If we want to do our procedure to this patient, factor VIII levels should be 50 to 75% for dentoalveolar surgery. Now, hemophilia B, it's Christmas disease. It's factor IX deficiency, and we treat it with fresh frozen plasma. For hemophilia C, it's Rosendahl syndrome, factor XI deficiency, and we replace factor XI or fresh frozen plasma. Now, von Willebrand disease, it's a pseudohemophilia. It's the most common inherited bleeding disorder that we take from our parents. Now, here we have factor VIII deficiency and von Willebrand factor deficiency. So we will have prolonged bleeding time, prolonged PTT, normal PT. Okay? Type 1 is defective, and it's the most common type, 80%. Type 2 is deficient, 15%. And type 3 absent. We don't find any of it, 5%. Desmopressin works at type 1, 2, and 3 need replacement therapy. Now, between hemophilia and von Willebrand disease, bleeding time is normal in hemophilia and prolonged in von Willebrand disease. After extraction, in von Willebrand disease, the bleeding will start immediately for up to 24 to 48 hours and often controlled by pressure. In hemophilia A, it's usually not controlled by pressure. Starts 1 to 24 hours after the trauma, lasts 3 to 40 days. And fixing this problem. Now, in Jordan, we're allowed to work up to INR 2.5. But according to Scully, it says that we can work up to INR of 3.5. So 3.5 is the maximum. Then we do local hemostatic measures, the one we talked about, suturing, sponge, local, and all that. And then we give and then we can send the patient home. The antidote for warfarin, it's a vitamin K antagonist, so it's vitamin K. But the problem with vitamin K is that it takes long time to work. It takes long time to work. Now, warfarin and general anesthesia, what to do? So you have different approach, the different procedures, different approaches that we can use for this patient. So, first, if medically applicable, we stop warfarin 4 days before the procedure and we resume it after surgery. If medically appropriate, to stop it. Now, the other form is that we stop warfarin 4 days before our procedure. We bridge with enoxaparin 1 milligram per kilogram subcutaneous twice daily, and then resume warfarin after surgery. We hold enoxaparin the night before and the morning of the procedure. Then the evening we continue it after we can confirm that there is no risk of bleeding. Now, enoxaparin is a low molecular weight heparin. We can stop warfarin 4 days, bridge with unfractionated heparin, resume warfarin after the surgery. Hold heparin 6 hours before the procedure and resume 6 hours after surgery. Now, once we bring them back, once we resume the dose after surgery, we give both unfractionated heparin and warfarin, or enoxaparin and warfarin. Because warfarin, as we said, it needs 3 days to start working properly. So in these 3 days, the patient is susceptible to DVTs, to MIs, to all kinds of clotting disorders. Now, what medications can we give to a patient with or on warfarin? Now, as analgesics, acetaminophen, paracetamol, celecoxib, codeine. Avoid warfarin. Avoid analgesics with warfarin, aspirin, nonsteroidals, tramadol, and so on. Antibiotics, we can use azithromycin, cephalosporins, clindamycin, erythromycins, amoxicillin with clavinic acid, amoxicillin alone. These are safe. Now, the old said that they were not safe, but with warfarin we can use amoxicillin and clavinic acid.